Hello again, and welcome to another session of Surgical Pathology Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and our program is a joint venture of the Digital Anatomic Pathology Academy with the DPA and PATH presenter as facilitators in this project. I'm coming to you today from the campus of the Oklahoma Health Sciences Center, where the Stevenson Cancer Center is an NIH designated cancer center and one of the highest enrolling centers in the nation for patients enrolled in clinical trials. Our case today comes from the cancer center. It's a 53-year-old woman who has an ovarian mass. Of note, she has a remote history, uncertain how long ago, of a contralateral oophorectomy and appendectomy. So a little suspect there in terms of history, particularly when we see that her neoplasm here is one of multiple cystic spaces with areas of sort of eosinophilic secretion, maybe some necrosis, and so forth. So let's focus first here on what sort of epithelium we're dealing with here and what degree of atypia we have. We see there's some complexity to these glands, some heaping up, some villous forms, some papillarity to this. And of course, usually on the gross examination, you would sense that this was a mucinous neoplasm because the fluid that would be exuded from these spaces is very gooey and slippery, as mucin typically is. Well, we see that that's true here. We have abundant pink cytoplasm, basal nuclei. We also see that, hey, there's a few goblet cells here scattered about. So that right away gives us a clue that this is an enteric type phenotype in the mucinous neoplasms. We can see that there's some atypia, but by and large, the cells are mostly basally located. We have some underlying stroma without any evidence of single cell or desmoplastic type responses or infiltrative patterns. We could look for pushing type of invasion. But we do see here, as we move into this second tissue fragment here, that we've got some sort of necrotic changes here. We've got some mucin that's sort of bulging or erupting into the stroma. And that's producing a reaction pattern with regenerative or regurgitation back into the lumen of this cystic space of some blood, fibrin, and neutrophils. So it looks like we're getting some extravasation of mucin into the stroma. We've got some incomplete glands, as we see here. Epithelium comes around here, comes around, and then it starts to disappear, and we have this eruption of fibrin, blood, and inflammatory cells back into the lumen. Then we pick up the epithelium again here. So this is a classic feature of sort of tumor-like diathesis that in some organs is the sine qua non of invasive neoplasia. Additionally, we see here that we have these pools of mucin. Here, we'll just sort of outline. You can see this whole pool here is just mucin with no epithelial cells. And looking adjacent to it, we see here's some epithelium and here's some, but no epithelial cells within those mucin pools. So while this is a criterion that makes us suspicious in the ovary, this is not a criterion of malignancy in ovarian mucinous neoplasms until and unless you find malignant epithelial cells floating freely in this pool of mucin. You usually would not call this, frankly, carcinoma. But certainly it raises concern. Looking a little further, here we see there's been some generalized necrosis, perhaps a vascular-related issue. And looking at the rest of the tissue, we again see this same pattern of extracellular stromal mucin-like granulomas with eruption of debris into the lumen of the cystic spaces, but no desmoplastic single-cell infiltration, and really not too much in the way of high-grade atypia. Even in these very cellular areas here, we don't see intraepithelial carcinoma or any sort of high-grade dysplasia. So, what are we going to do with this? This is a diagnostic challenge, particularly in the setting where we don't have the contralateral ovary and the appendix has been removed. We've talked about mucinous neoplasms in the ovary before, and as you know, there are two distinct types. There is the enteric phenotype, such as we have here, which tend to be CDX2 positive and CK20 positive. And then there are those that are more endocervical-like, that will not have CDX2, may have PAX8 and CK7 positivity. However, these enteric types can be either primary or secondary. So this can be a primary ovarian tumor, but it can also be a secondary tumor, representing spread, usually from an intestinal source and most commonly the appendix. So when we find such a tumor on a frozen section, we don't know what's going on, but this should prompt search. We need to go after these and encourage the surgeon to look and consider what's going on in the bowel. Likewise, once we have the specimen, we need to sample it very generously to make sure that we don't have high-grade epithelium or any evidence of invasion. Now, the real problem here is that low-grade mucinous appendiceal tumors, so-called LAMN, are particularly easy to miss, both in the appendix and as a primary tumor or as a secondary tumor in the ovary. And certainly, if we don't have pseudomyxoma peritonei, meaning free-floating mucin within the peritoneal cavity to suggest that we've had an appendiceal rupture, we may not make the correct connection with the appendix. Here's an example of an appendix that has a large blob of mucin within the lumen and has abundant extracellular mucin, some inflammatory reaction with blood and fibrin. You can see just how serious and inflammatory this process is. But notice here's the mucinous epithelium, and it's very benign looking, very minimal atypia, basal-oriented nuclei, and not much in the way of any sort of significant cytologic atypia, other than a little bit of crowding, a little bit of tufting. So these can be particularly hard to miss. Let me show you a similar example and show you the reason why. So here's a normal size appendix, and here's the distal appendix here, which shows you that the appendix is not even dilated, or very minimally so. And so when we come down and look at this and see that, yes, this is a mucinous neoplasm of the appendix, it's very low grade, it's got this enteric phenotype and so forth, it's got this borderline tufting and papillarity to it. These lesions can metastasize and spread without there being always recognizable penetration through the wall. And that is what makes this particularly difficult in the setting of an ovarian tumor at a later date, which could easily be mistaken for this. So where does that leave us today? Well, without having the prior appendix or ovary for examination, we can't tell. Essentially, we have a low-grade mucinous neoplasm. It's enteric phenotype, but we cannot distinguish whether this came from the appendix or whether it came from a primary mucinous borderline tumor, either in this ovary or in the prior ovary. Sometimes we're left with a little bit of uncertainty. That being said, management of this lesion should be probably followed based on the worst case scenario. Careful inspection to make sure that there's not pseudomyxoma peritonei or other primary sites from the gallbladder, pancreas, stomach, et cetera, and with that being clear, then the patient should be able to be expectantly managed. Well, thank you very much for joining you. I know that we don't always get things completely clear, but we can usually provide the next stage of management, which is, I hope, what we were able to clarify today. So if you like this, please subscribe and add your comments, share. We're happy to reach a broad audience of people trying to learn a little bit more about surgical pathology, and we will plan to see you again soon.